Hi everyone, my name is Stephanie Plake. I'm going to give my presentation on beta blockers with more of a focus on the diseases that beta blockers are used to treat. So we're going to start out with this overview here. We're going to first start out with in this presentation a brief history and overview of beta blockers, some common diseases that beta blockers are used to treat, and the mechanism of action. There's going to be like a focus on like some cell signaling pathways so that you can understand exactly how the body interacts with certain diseases and how beta blockers interact with those things in the body. And also problems associated with beta blockers, meaning like their side effects and if they're really effective. So we're going to start out with a history of beta blockers first, very brief. I wanted you guys to understand the timeline involving when they were created and what they were used to treat, as they were not as novel and as they were progressively becoming more popular and being prescribed. So they were initially created in the 1960s. They were mainly used to treat angina pectoris and cardiac arrhythmias. By the 1970s, beta blockers were used to treat hypertension or high blood pressure. In the 1980s and 1990s, beta blockers were considered first-line treatment for hypertension. Because beta blockers are found throughout the body, beta blockers are now used to treat a variety of diseases. Now I would just like to remind you all of the function and location of beta blockers. I mentioned this in my short presentation previously, but I focused mostly on beta adrenergic receptor 1 in my last presentation. This will give you guys some more detail about the other receptors, their functions, and locations. So now we're going to talk about beta 1 androgenic receptors through beta 3 androgenic receptors. So let's get going. So beta androgenic receptors 1, beta androgenic 1 receptors, are found mostly in the heart. They're found in a 70-30 ratio with beta 2 receptors, so there's a greater amount of beta 1 receptors in the heart than there are beta 2 receptors. Beta 1 receptors help increase heart rate and contractility. They are also found in the kidneys, and they stimulate the release of renin. If you don't remember what renin is from previous classes, since I know that we're all biology majors and I'm sure that we've all at least heard about the renin-angiotensin-aldosterone system, I'm going to talk about that in my presentation later, and I'm going to do a recap of what exactly occurs in the pathway, just as a refresher. So beta adrenergic 2 receptors are found in quite a few organs, more so in comparison to beta 1 receptors. They're found in the lungs, the gastrointestinal tract, the liver, the uterus, vascular smooth muscle, and skeletal muscle. They function in assisting with bronchodilation, metabolism of carbohydrates through hepatic and skeletal muscle glycogenolysis. They assist in the release of pancreatic insulin and in the vasodilation of arterial walls. Just a side note, some alpha-1 receptors also play a role in the regulation of carbohydrate metabolism. Some new beta blockers target both alpha-1 receptors and beta-2 receptors. I will talk more about this later in my presentation, but I just wanted you to be aware right now presently since I'm just talking about their functions and there's overlap. So now we're going to talk about beta 3 receptors. They are found mostly in fat cells, and they function by mediating lipolysis, so the breakdown of fat cells, and thermogenesis, which is the creation of heat. They mostly remain inactive in basal conditions, but under intense androgenic activity, they are activated and impose negative inotropic effects. I wasn't sure what inotropic meant, and I had to look it up because I'm silly. And inotropic means that they affect the force and speed in which muscles contract. So they negatively affect how muscles contract. Now I would like to talk about selectivity of beta blockers, but first I need to define selectivity, I feel like. So selectivity is defined as the degree to which a drug acts on a given site relative to other sites. For example, the binding of a drug to a receptor. A drug's ability to bind to a receptor is due to the chemical structure of the drug. So the chemical structure of the drug has to match the receptor that it binds to. If the drug does not match the receptor that the drug is supposed to bind to, it can't bind to it. It doesn't fit. I know that we were always taught about like a lock and key mechanism in our physiology classes, and I feel like that's pretty accurate. A lock and key. You can't fit someone else's key and you're locked to get into your house. That would be terrible, right? There'd be so many break-ins. So there are 3 generations of beta blockers. It seems that with each generation, a trend that I've noticed is they start to target mostly a certain type of beta adrenergic receptor. So there's been like more advances probably being made as beta blockers have been on the market for what they can target. So generation 1, they are non-selective and they target beta blockers all over the body. So if you can imagine, there's probably like some really weird side effects from all of the things that beta blockers that are non-selective target. And generation 2 beta blockers target beta androgenic receptor 1 receptors. They target beta 1 androgenic receptors more than beta 2 androgenic receptors. And then generation 3, it's a newer generation. It's pretty novel from my understanding. I think that the article that I got this information from was published in 2011. They block alpha-1 receptors and stimulate beta-2 receptors. So these beta blockers are structurally different than other beta blockers. They help to improve endothelial function and anti-hypertensive action without an effect on cardiac output. Sorry, you guys probably just saw my notification from email because I'm recording my screen. Just want to apologize for that. So if you can imagine, they help lower your blood pressure, but they don't affect cardiac output. So there's probably less severe effects with a prescription for generation 3 beta blockers. So cardioselective beta blockers are beta blockers that target mostly beta 1 receptors. There are a lot of beta 1 receptors in the heart, like I mentioned before. The heart has a ratio of 70 to 30 beta 1 receptors in comparison to beta 2 receptors. So there's quite a bit more, almost double, beta 1 receptors in the heart. There is no such thing as a beta blocker specific for just beta 1 receptors. And to be clear, as the prescribed dose of a beta blocker increases, specificity decreases. So they have an inverse relationship. So you give someone more beta blocker, a higher dose, that is going to be able to, I guess, diffuse more throughout the body and target more beta receptors. It's going to mess with more beta receptors in your body. So they try to really like hone down on the dose to make sure that that doesn't happen. So now I'm going to talk about how beta blockers are metabolized. This is important when considering what beta blockers are used to prescribe, because you need to take into consideration the patient's medical history. So if a patient is on dialysis, for example, the beta blocker they are taking can be dialyzed off and removed if it is hydrophilic. Supplementation is necessary after dialysis to keep their plasma levels consistent. I will talk more about dialysis later in my presentation, though. I just wanted you to have that example for why metabolism is important to consider. So beta blockers are either metabolized by the liver or kidneys. Beta blockers that are metabolized by the liver are lipophilic. They have longer half-lives and they penetrate the blood-brain barrier and can have neurological side effects. Beta blockers that are metabolized by the kidneys are hydrophilic. They have shorter half-lives, so multiple doses are often required. So while doing research for this presentation, I found some conflicting information. This information here on this slide implies that hydrophilic beta blockers that undergo renal clearance are the only beta blockers that would require multiple doses due to their short half-life. But propranolol, which is a lipophilic beta blocker, also requires multiple doses. So to solve that problem, researchers examined a medium to slowly release propranolol and maintain plasma levels. Here's some background information on the beta blocker propranolol before I get into the study. So propranolol is a beta blocker. It has a half-life of 3 to 4 hours. It is cleared by the liver. The typical dose is 40 milligrams 2 times daily to 4 times daily when treating hypertension. Researchers tested the following mediums to use potential matrices to slow the release of propranolol. There was guar gum, xanthan gum, and hydroxypropyl methylcellulose, which is a mouthful. They found that hydroxypropyl methylcellulose wasn't comparable to guar gum and xanthan gum. Guar gum and xanthan gum had the same effect when mixed at the same ratios, so performance was not benefited by a higher ratio of one or the other when mixed together. But xanthan gum, when in comparison, when it was just by itself, in comparison to only the guar gum, when the guar gum was just by itself, did not compare. Xanthan gum kind of blew guar gum out of the water, and it was the best at retarding the release and diffusion of propranolol, allowing for a better and more consistent level of propranolol in the blood plasma. So now I'm going to talk about hypertension. I talked about this pathway in my short presentation, but I just wanted to remind you guys briefly that beta blockers act as agonists, blocking the catecholamines, adrenaline, and noradrenaline. I'm still saying catecholamines wrong, and Dr. Stark isn't here to correct me, so I'm sorry. The G subunit in the beta blocker of the beta-1 androgenic receptor, upon activation, upregulates adenylyl cyclase, which converts ATP to cyclic AMP. With the increased presence of cyclic AMP-dependent protein kinase A phosphorylates calcium channels, which increases cellular calcium influx. Increased concentrations of intracellular calcium increase entropy in the heart through calcium exchange in the sarcoplasmic reticulum. So it causes more contractility in your heart. The fight or flight response is prevented with a beta blocker, if that is in your system, which reduces cardiac contractility. Renin release is also linked to hypertension. So I'm going to start talking about other diseases now, but before I do that, I would like to remind you guys of the renin-angiotensin-aldosterone system pathway. I'm sure you're all familiar with it, but just to recap, there's a link between the system with hypertension and chronic kidney disease, so that's kind of why I wanted to remind you guys what happens in it exactly. So the first thing that happens is renin is secreted from the kidneys. Renin then converts angiotensin 1 to angiotensin 2. Renin then converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin-converting enzyme, allowing for us to feel thirsty. So we take in more water, vasoconstriction occurs, and sodium is reabsorbed to hang on to more water. Aldosterone is then triggered, which allows for the reabsorption of sodium and potassium excretion in order to further retain water. Chronic kidney disease is a slowly progressing disease that is characterized by kidney damage and worsening glomerular filtration rate, or GFR. There are 5 stages of chronic kidney disease. In stage 1, there is damage to the kidneys, but GFR remains normal. In stage 2, there is kidney damage and mild loss of function with a GFR functioning at 60 to 89%. Stage 3, there is moderate to severe loss of kidney function with a GFR functioning between 30 to 59%. Stage 4, there is a severe loss of function of the kidney with a GFR functioning between 15 to 29%. And stage 5, there's kidney failure requiring treatment with a GFR functioning at less than 15%. So when you have kidney failure, when you're in stage 5, you're more than likely going to need dialysis. So in chronic kidney disease and normally functioning kidneys, afferent arterioles constrict more in comparison to efferent arterioles. In kidneys with impaired function, efferent arterioles constrict more, leading to an increase in intraglomerular pressure. Increases in intraglomerular pressure can cause hypertrophy in cells of the kidney, which causes the progression of chronic kidney disease. Chemoreceptors and baroreceptors found in the kidneys send signals up to the hypothalamus, and when kidneys are damaged, this is overly active and can lead to an increase in concentration of catecholamines in the periphery. Angiotensin 2 is found in higher concentrations in circulation. That's a common characteristic of chronic kidney disease. Angiotensin 2 plays a role in the release of adrenaline and vasoconstriction. Angiotensin plays a role in the release of aldosterone. Aldosterone assists with sodium absorption, like I mentioned before, and the absorption of sodium can lead to elevated blood pressure. And when functioning normally, the renin-angiotensin-aldosterone system plays a large role in controlling drops in blood pressure or hypotension. And when overstimulated by the sympathetic nervous system, it can lead to hypertension. So what is dialysis? Dialysis is the process of removing excess water, solutes, and toxins from the blood in people whose kidneys can no longer perform these functions naturally. Hypertension and CKD requiring dialysis go hand in hand. This is due to extracellular fluid volume overload and overstimulation of the sympathetic nervous system. Patients requiring hemodialysis often have diabetes as well, Arteriosclerosis can be perpetuated by hypertension and diabetes mellitus. So here's a table showing some beta blockers that are commonly prescribed. Some beta blockers are better in comparison to others because of their effects on the body. It looks like, for example, some increase GFR while others maintain it, and some increase insulin sensitivity while others decrease or maintain it. Things like that. So things to consider: non-selective and cardioselective beta blockers can have detrimental effects as it can increase insulin resistance. Non-selective beta blockers are also associated with compensatory stimulation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. A study performed by Luno, Veras, and Ramos, with many other contributors, found that patients placed on a beta blocker in combination with a ROS blocker, like an angiotensin-converting enzyme inhibitor, showed a decrease in cardiovascular events and death resulting from cardiovascular events. The effects are better in comparison to using one or the other. Now I'm going to talk about congestive heart failure. Congestive heart failure is caused by the overstimulation of the sympathetic nervous system. Overstimulation of the sympathetic nervous system leads to an increase in cardiac output and muscle contractility. This makes heart muscles floppy, and therefore they do not beat as strongly. You can see from the picture a comparison of what a normal heart looks like versus one with CHF. There is an enlarged ventricle, and the shape is a little weird in comparison also to the normal heart. So the clinical signs of congestive heart failure are an enlarged left ventricle. There are higher concentrations of adrenaline, angiotensin II, aldosterone, endothelin, which is a vasoconstricting peptide functioning in helping control vascular homeostasis, and vasopressin that helps maintain the correct balance of extracellular fluid. And just as a reminder, signs are things that doctors measure, symptoms are subjective, so you won't be able to tell these things, obviously, if you have congestive heart failure. So beta blockers are commonly prescribed as treatment for CHF. However, it is reported that CHF may become worse. So researchers that were concerned with this performed a study to see when beta blockers became effective. Patients treated with metoprolol initially showed a decline in ventricular function, but this improved between 1 to 3 months of treatment. Left ventricular function returned back to normal, left ventricular mass grew smaller, and the heart returned to a more elliptical normal shape at 18 months. So now I'm going to talk about some issues with beta blockers. These are all the listed side effects of beta blockers, and there are a bunch. So many side effects. Some are pretty ridiculous in my opinion, like depression, insomnia, dry eyes, eye irritation, flatulence, upset stomach, and nasal congestion. The list of ridiculous symptoms goes on. You can feel free to pause this and look at this because it's weird. It is hypothesized that the reason why more people are not prescribed beta blockers is largely due to the side effects and lack of clarity on which are genuinely caused by beta blockers. To determine what was real, a meta-analysis was performed. Researchers calculated the frequency symptoms appeared and interpreted this to mean the more frequently symptoms appeared, the more real the symptoms were. And logically, this makes sense because of the incidence of people experiencing side effects was greater for some symptoms than others. Why wouldn't that be a real side effect? Researchers found that common side effects were hyperglycemia, diarrhea, bradycardia, dizziness, and claudication. The most uncommon side effects were tachycardia, insomnia, depression, palpitations, cardiac failure, and chest pain. So now I'm going to talk about another problem with beta blockers. It's a phenomenon called new onset diabetes mellitus. So new onset diabetes mellitus literally means new onset diabetes mellitus under antihypertensive treatment. It can be attributed to decrease in secretion of insulin, decreased insulin sensitivity from reduced blood supply, increased body weight, and increased gluconeogenesis from glycogenolysis. So is new onset diabetes an issue for concern? Is this really for sure happening? A meta-analysis of studies was performed by researchers. It showed that there was a 22% increased risk for the development of new onset diabetes. So people who are obese, have a higher fasting blood glucose level, and have higher systolic and diastolic blood pressures are more at risk of developing new onset diabetes. So yeah, from this study that the researchers performed, it was definitely of concern. Definitely real. Finally, I know I discussed hypertension earlier, but I would like to examine just how effective beta blockers are at treating hypertension. Luckily, researchers were also curious, so a meta-analysis of studies was performed to assess how effective non-selective beta blockers are at controlling blood pressure. Systolic blood pressure was reduced by 10 millimeters of mercury when a beta blocker was prescribed. Diastolic blood pressure was reduced by 7 millimeters of mercury. This reduction is not statistically significant because between the two reductions, the total decrease in pressure is about 2 millimeters of mercury. So there are more effective medications in controlling hypertension, like ACE inhibitors and calcium channel blockers, but I'm going to leave those classes of drugs for you all to look up. I feel like I've gone way down the beta blocker rabbit hole with this research project, but I've really learned a lot, and I hope you guys all did too. So thanks for listening. Here are my references, and that's it for me.